Greetings and Happy New Year. Happy 2026 and welcome to the first CHAPcast of 2026. I'm Jennifer Kennedy, the lead for quality and compliance at CHAP, and welcome to our CHAPcast for 2026. And it is the topic of top 10 home health deficiencies today. And I'm with my compadre and coworker and friend, Kim Skian, and we will regale you with the top 10 CHAP survey deficiencies specifically for home health. And I did a lot of work. This is something that I haven't done a lot of work on in the past, but now we've shaken things up a little bit, and quality is taking a bigger lead on top 10 deficiencies with a handshake with Kim's team and accreditation. And it's quite an eye-opener when you look at those top 10. So Kim, let's go ahead and jump in and let's talk about the roadmap that we're going to use for this conversation.
Sure. Thanks and welcome everybody. Happy New Year. I know we're nearing the end of January, but as our first CHAPcast, I thought I would set the stage and say Happy New Year, and really hoping for a positive new year, a year ahead for all of us, and both providers and accreditation, or us as an AO, as well as, of course, patients and their families. So we really do appreciate you joining us to receive this information. I just want to point out that, first of all, the top 10 deficiencies in any service line, in this case home health, are extremely important because they do highlight what is most commonly cited. It's important to know that these are our CHAP top 10, but they actually closely align with CMS top 10, likely other AOs, and certainly state agencies. So even local from a state agency, you'll see that these are quite common. And as Jennifer will point out when she talks about some of our additional resources, have also been trends or common over time. It's important that agencies look not only at the top 10 for survey readiness and compliance, but all standards and tags. And in our case, we have our CHAP standards. These top 10 standards align with G tags, or conditions of participation, or CMS standards. So it is important that compliance with these standards is of utmost importance to avoid not only CHAP required actions, but also potentially deficiencies, condition or standard level deficiencies during the survey.
That's great, Kim. And I think it's really important that folks be aware that this is another data source for benchmarking, right? You need to take all your data sources when you can get them, from wherever you can get them, to really benchmark your performance against that data, because that's the only way you'll be able to find gaps in your performance and be able to shore them up through your QAPI program. So even though maybe you did a great job, maybe you had a CHAP survey this year and you did a great job on it, and you didn't necessarily have many of these or any of these deficiencies cited, it's important to pay attention because it is another data source, and we need to be data-driven in healthcare in order to be meaningful in our performance improvement. So let's take a look, Kim, at some of the deficiency highlights. If you would run us through some of those.
Sure. Top of the list, and it has been for the past few years, and honestly, I would say for all service lines, or certainly most of the service lines over time, not just with CHAP, but in general, we call it APC 10, but it's G574, the content of the individualized plan of care. This is a perpetual top deficiency, and it's really a reminder that the care plan must reflect the patient's individual needs and be updated at least every 60 days or more frequently as needed based on changes in the comprehensive assessment and any other changes. The updates relate to another top 10 finding, which is also G572, also in the top 10, a little lower down. But the bottom line is that, you really have to focus on what matters most to the patient. Yes, you have to have orders and individual interventions and goals and frequencies for all disciplines and all of the, basically conditions that are pertinent to the plan of care, and especially that you're providing service. But you want to focus also on what matters most to the patient. For those agencies that choose to become age-friendly healthcare at home certified, they understand this because there are the 4 M's, right? What matters most: mentation, medication, and mobility. But for any organization, this should be a key driver for all care planning to ensure that the plan of care, treatment, and services are individualized to meet the patient's needs. We did record a previous CHAP cast on focusing on case management, which is the responsibility of the primary care clinician in conjunction with the organization's IDG or IDT, other disciplines, to ensure that there is effective case management leading the care to make sure that all disciplines, all care services and treatments are reflected.
Let's talk documentation for a sec, because the electronic medical record is a blessing and a bane. Let's be honest with this, and we are in a time, it doesn't matter whether you're home health or hospice or, whatever your provider type is. We are way past just pointing and clicking. Yep. We can't, as healthcare providers that want to defend their documentation during a survey, during any kind of an audit with an audit entity, such as your MAC or your SMRC or whoever it might, RAC, whoever it may be. You have to go beyond point and click, and that's the same for your plan of care. So it has to, you have to actually do free texting in order to make that an individualized plan of care. And an organization who's not requiring that of their clinicians is not smart in terms of that proactive defense they need to make for surveys and audits. And we're not probably getting that full picture of the patient without free text individualization as well. So I felt like compelled to drop that in there, because a lot of the EMRs, are just, to use the time-worn phrase, cookie cutter phrases, and you can't rely on point and click at this point in the healthcare environment.
I completely agree, both from a survey regulatory standpoint and, of course, payment, as you pointed out, payment and audit standpoint. And we're talking about the care plan, but this also includes visit notes, because it is in the visit notes and the summaries that really paint the picture to then be able to build on the change in the comprehensive assessment and subsequent, care planning changes. I will say that I will give a shout out to many of the EMRs that we work with. They've come a long way over the years, that there is an ability to be able to modify any, standard text that's there, or, edit to make sure that the plan of care does reflect the individual patient's needs and goals. But to your point, it really is up to the organization, the agency, to know, to ensure that the staff are going beyond the point and click to paint the picture of the patient.
Absolutely. So I know we have a few more that stand out as well.
Oh, yes. Medication review, we know that, we look at the medications. G536 is the comprehensive assessment that includes the med review. We also have presented on this topic as well. It is a perennial top issue, and it's really related to ensuring that the medication management as part of a key care planning and assessment responsibility is completed ongoing. And the review that the medication, it includes a review that all the medications that the patient is currently using in order to identify potential adverse reactions, effects, drug reactions, interactions, and significant side effects, duplicate drug therapy, etc. We at CHAP recommend as a best practice, it's not a regulatory requirement, we do recommend full medication reconciliation during all nursing and or primary clinician visits, so that the medication profile is aligned with what we have in the record, physician orders, and also what the patient is taking in the home or facility. Remember, in home health, we serve patients in assisted living facilities, group homes, residential care homes. So it really is important that all of those lists combine and the patient understands, what it is that they are taking. And the question for every visit is not, have you had any changes to your meds? Because inevitably, there will be one missed, and it'll be found when a surveyor is conducting and does a full med rec. So when we say med rec, it is a full-on review what's in the home, what's on the patient list in the home, what's in the EMR. And because remember, we also have to provide that in writing, and also what we have for physician orders. And it includes prescription, non-prescription meds, and herbal remedies. Anything to add, Jennifer?
Well, we just happen to have a really nice resource that we created towards the end of 2025, which is a blog on medication reconciliation. So we'll include a link with that in this podcast so our listeners can easily access that.
Absolutely. Yep. Another is that we do see in the home really is that there is not evidence of the written visit frequency and scheduling and patient notification. We know that under 48460E, there are several requirements that need to be, it's specifically written information in the home that needs to be left in the home, which also implies updated. Now, I just want to point out, really here is the whole reason behind it is, number one, a patient rights issue to ensure that they are informed of the care that's being provided and what services are treating the patient and when they're coming again. And also to make sure that the visit frequency matches physician orders and the care plan. But there's not one specific way that this can be provided. It really does depend on the agency, your agency, and the patient. So some patients want a calendar on the fridge, or they have the pre-printed list that the agency provides, or they may also use I've seen whiteboards, right, where that's where the patient chooses to have the information. One point I want to make is we are seeing more frequently the use of the portals, right. The health data portals, the ones between the physicians, and my chart, I guess, is just an example of one. That is actually okay and will suffice to meet the written requirement as long as the patient and representative understand that's where this information is and can access it. And because, on a survey, if that's the mode of communication, we would ask them to pull it up to validate. And they also should be verbally informed with each visit and also informed of any scheduling changes.
Dare I say that's individualizing the care, isn't it?
Yes, it is.
Back to issue 1.
Absolutely. Another is the patient rights requirement that patients must receive a written notice in advance of care being furnished. if there's a possibility of not providing care, providing covered care, or in advance of reducing or terminating ongoing care. This information must be provided both orally and in writing in advance of patient care being initiated and whenever there is a change or termination of care. And just remember that for this, specifically related to home health, there is a CMS documentation requirement in addition to the documentation in the record that indicates that the patient has been informed. And those include the home health change of care notice, the notice of Medicare non-coverage or NOM-NOC, the detailed explanation of non-coverage, and ABN or advanced beneficiary notice. Those can be found on the CMS website, but I think EMRs and documentation systems also have them. But it is important that from a regulatory and payment perspective, that an agency does make sure that they are providing those documents as appropriate.
So we looked at some documentation issues. So let's hop to infection control. Did you hear the sigh?
Oh, I'm waiting for that sigh for the next one we talk about too, Jennifer. Don't worry.
Oh, yeah. Yeah, infection control, not compliant. Fill in the blanks, Kim.
Well, 9 times out of 10, most often, infection control findings are related to a home visit. They have to do with hand hygiene or a facility, in this case, a home visit. Hand hygiene and bag technique and equipment management. So sometimes we'll see it with expired supplies, in supply rooms or in trunk boxes, where that's can be a cave of who knows what's in it,
Absolutely.
So they do make sure that they check them. Supervisors should be checking them ongoing. There also are some infection control findings related to, for example, the agency's policy on TB testing or, other health requirements. But specifically, most commonly, the hand hygiene policy and or CDC guidance, and the CDC guidance is not being followed. They're not washing their hands before they enter the bag between treatments. For example, they are, using their phone as a piece of equipment, sticking it back in their pocket, picking it back out, and not washing their hands again. If you're using the phone, just like a laptop or a tablet, it's a piece of equipment. And then agencies often get hung on, honestly, their own policy when it comes to bag technique and equipment cleaning and management. Because if your bag technique policy says you cannot have place the bag directly on the floor, without a barrier, or you need a barrier, that's, and someone misses that, that is a finding. Also, if your equipment management policy says equipment will be cleaned following manufacturer's guidelines. And those manufacturers' cleaning guidelines, for the product they're using, says you have to clean this for 2 minutes and let dry for 2 minutes. That they really have to make sure that they are, that their policies are reasonable, following the CDC guidance. And I think the SOM State Operations Manual has some really good guidance, I think, in the infection prevention and control section.
Absolutely. And even though, we're way past, a pandemic, we still need to be mindful of infection control.
And standard precautions.
Following the policy. Yeah, absolutely.
Yeah.
All right. Let's go to the next one.
No. I'm
hiding my eyes.
I know you are, but guess what? I'm tossing to you on this one because I know it's your favorite. We've been talking about it, my gosh, for 20 years, Jennifer. I feel like you and I have been like the bane of our existence, this one. So would you like to tee it up?
Right?
Yes.
It's the supervision minimally every 14 days, and we have deficiencies in this area. And it is what it is. It has to be done. Either you're going to have your nurses track it, or you're going to have somebody else track it internally and queue your nurses and your aides. This, to me, should come off the list soon and stay off the list.
We've been saying that
it's
for
a
many
matter
years.
of it's a matter of counting when it's due and actually doing it and documenting that the supervision was completed. So, yeah. It's a sad day when I open them up and see that this is on the list. Gosh.
I don't know what we'll do when it's not anymore, Jennifer. I mean, really.
Well, we'll have a major celebration.
I will add, let's remind, as a reminder, for that aide does not need to be present.
Correct.
This is supervision of the RN or the primary clinician supervision of the care plan, and there are specific, in the standard, specific questions or areas that the person conducting the supervision would follow. In fact, most of the EMRs, or many of them, have those listed right out. And another best practice, again, not required, but a best practice is to conduct this supervision with every visit, every RN, every primary clinician, if it's a PT only case, for example, so that we don't miss it. There are also, what we're seeing very recently is an issue with GA10, which is the documentation that talks about the ability to have one virtual supervisory assessment in a 60-day episode. And it's it's very clear that it says a rare occasion. It be needed, and it only, this virtual supervision only applies to the patients that are receiving skilled services and aid services under a skilled plan of care. For non-skilled patients, they're required to have that supervision every 60 days. Again, the aide does not need to be present, but you also need to look at your state requirements, because state regulations very often are more stringent. So you want to make sure that the agencies need to make sure that you're meeting those requirements, and that this supervision is separate from the annual or semi-annual for non-skilled, but there is an on-site visit requirement. So
this sounds like we need to
with the aide present, huh?
This sounds like we need to do a blog.
Man, do we ever? That's for sure. And it is hard to keep up with, which is why, as we say, with MedRec and supervision, just do it every visit. Every visit, because every RN or primary clinician visit, because it does get to be, it's tough to track.
Absolutely. All right, Kim, let's talk about how this year's really tippy top deficiencies compare to last year's.
Yeah, I mean, as we have already, indicated, several that we have discussed already have been on in previous years, but G574 remains as number one. And the written instructions and site visit schedule does remain at number two. Again, most of these other findings have also lived in the top 10 over the past few years. The one that has become more prominent in the last couple of years is the transfer and discharge documentation, specifically related to the timelines. Remembering that they must be provided not only they need to be provided to the physician and within 5 business days of a discharge and 2 business days of a transfer. Once we know of the transfer, if the patient is still in a facility, is still admitted or transferred, and that evidence to make sure that it's clear. I'm going to use a fax. I'm old. So like fax, the fax statement or whatever the tracking is inside the EMR, they have to be able to demonstrate not only that it was completed in that time period, but that it was sent to the physician and the facility.
All right. Well, that's a good overview of comparison. So we have some new tools to announce to our customer base for home health. And I'll just take a couple minutes, Kim, to talk about how we shook it up a little bit to make it a little more helpful for our home health customers. Not only were we giving you a top 10 list this year for 2025 deficiencies, and these are standard deficiencies. We're also giving you an analysis of those top 10 broken into domains. So you'll be able to look at your top 10, scroll down on that sheet, and see an analysis of why what is the rationale and why the standard is important, some key actions to take, and then some performance improvement suggestions for you to take if that's an issue for your organization. And then another tool that I'm really excited about that we're doing not only for home health, but each of our provider types that we credit, we're doing a 3-year top 10 deficiency comparison chart with analysis. So we're going in the short wayback machine to 2023 and giving you a side-by-side of 23, 24, and 25 top 10 deficiencies, again, with an analysis and an overall interpretation of the 3-year analysis of those top 10. So we're really trying to not just tell you here they are, like we have been in past years. We're trying to talk to you about here they are, here's why they're important, here are some things you can do, and here are some performance improvement suggestions. So I'm really excited about these tools that we're pushing out the door this year.
And Jennifer, you should be. I've seen the tools or as they're being developed, and they are incredibly helpful and informative resources for agencies to be able to use. And to your point at the beginning, this also provides yet another data point, right? To be able to, evaluate against their own compliance as well as, the industry. I also would add that our friends in Learning Solutions here at CHAP Center for Excellence, the team at CFE will be, and Learning Solutions is also partnering with us so that we can make sure that we are aligned in our own education to customers, but also that we have a consistent understanding and awareness of the challenges and these top deficiencies. But incredible work, Jennifer.
Yeah, it is. And CHAP is always trying to push the needle forward in terms of what we're giving our customers. So this is just another way to start 2026 off on a high note. All right, my friend, it looks like we're getting to the end of our time together. Any final thoughts?
No, I think, again, just going back to the beginning, this is one or two tools that organizations can use in their overall survey readiness and education. And, but it's part of the puzzle, really making sure that as an agency, you understand all of the conditions of participation, these CMS standards, CHAP standards, and conduct your own internal mock surveys, at least annually. I think I've been saying that for years, to be able to make sure that, you are in compliance, especially with, the changes, not so much the changes in regulation, but how your organization may apply them, especially if you've had change in management, leadership, or staff, because that also tends to be an area or a time point that there becomes issues. So I'm very happy that we have these resources now to offer.
Me too, Kim. Thanks. And thanks for teaming up with me today to talk about this important topic.
You're welcome.
So what we would invite you to do is, after you listen to this podcast, is click on some of the links to our resources, which include our top 10 home health survey deficiency list, our 3-year comparison, and then we'll also include that link to the medication reconciliation blog that we prepared last year. So thanks to all of you for taking time out of your day to plug into our podcast. From Kim, me, and the entire CHAP staff, keep your quality needle soaring forward, stay safe and well, and thanks for all you do.